Hello, eICU. This is Brian Klein. I am the clinical nurse expert for Medicine ICU and the CRRT nurse educator, and I am recording a recap for you guys for the nursing part of the CRRT SuperUser courses that occurred in February of 2024 this year. So our learning objectives for this module will be to verbalize updates for the CRRT program for 2024, demonstrate advanced troubleshooting using the PACE framework, and to identify proper documentation of CRRT, including calculation of ultrafiltrate every hour. First, we'll start with some nursing updates for 2024. So first and foremost, I want to emphasize that we are only using the Prismax at UK Healthcare at this time. Good Samaritan transferred over to the Prismax late last year. If a nurse is delivered a green machine, Prisma Flex, they are to return it. There's currently no plan in place, but if there is during an extreme event, and if we have the machines still available and functional, this will be communicated well into the future, so there should be no routine using of the Prisma Flex anywhere at UK Healthcare. Late last year, we transitioned into the ST series filters. They replaced the HF1400 that was used in the adult world, basically the whole time we've been on CRRT. And it replaced the M series that was used for pediatrics and neonates. Adults will use the ST150. Pediatrics generally uses the ST100, and neonates less than 20 kgs use the ST60. These arrived somewhat unexpectedly at the beginning of September, and we have been using them exclusively since. The differences between the ST series and the HF series are fairly minor as far as nursing is concerned. The membrane has a higher adsorptivity, allowing more medium-sized and large-sized molecules to adhere to the inside of the filter, thus rendering them out of circulation. They also have a graft where heparin can bind, and we'll talk about that next slide, to preserve filter life a little bit. From the bedside aspect, you really won't see much difference. The maximum lifespan is still 72 hours, although there is some expectation that the filter life may decline slightly as we are adsorbing more high-size molecules. And they are intended to be primed with heparinized normal saline, although this is not required. Heparinized normal saline went live a few months later in December. For adults, they should receive 2 liters of saline, each with 5,000 units of heparin injected. This will be done per pharmacy. The priming sequence should take both bags in their entirety, and there is no repriming with regular saline afterwards. The amount of heparin that is actually delivered to the patient is negligible. The total volume of the ST150 is only about 216 milliliters, and most of the heparin in that volume anyway will be bound to the ST membrane, not in the saline itself. This is obviously to be avoided in patients with heparin allergy or severe coagulopathy. For pediatrics, this will look a little bit different. They will get a 4,000 unit per liter bag of normal saline. Typically, they will be sent 2 bags just due to the order set, but only 1 will be necessary for priming. Ordering CRRT machines has not changed significantly. We have removed the row that allows you to select which machine, since we're only on 1 machine. The delivery and pickup model is the same. Nurses per policy are to request delivery through Epic through the order CRRT machine, with the room number mentioned in the comments. If they ask you to do that for them, this may be one of the areas where you can help out easily. The expectation is that you give Agility 30 minutes to deliver the machine, after which then you can go ahead and call them. The order will self-complete as soon as it is printed into the Agility office. So if you want to verify that the order has been placed, just go to the Orders History tab and filter by completed. The same process is expected when returning the machine back to Agility. This is an important quality improvement metric that we're tracking. Blood leak detected has not changed this year, but just as a reminder, the order is fairly new. and that can be obtained by aspirating a sample out of the yellow port on the CRRT circuit with a 21 gauge needle or smaller. Basically, that's any needle size besides blunt tips. And the order that's placed for the lab is body fluid cell count with differential. Make that stat, and the specimen source should be effluent fluid. Remember, if this comes back positive with anything other than 0, the set is considered contaminated and should be disposed of. And here is an example of what that result will look like. Typically, it comes back in 45 minutes to an hour. On extreme cases, it might take up to 2 hours. It can be collected in a clear specimen container or sterile container or a lavender tube, either one. As a reminder, it's important that we utilize our process for broken machines, which is a fairly common source of nursing frustration. However, we've had multiple machines returned and the technicians were unable to ascertain what the problem was, or it was determined to be user error, and we don't want nurses to have to waste a bunch of time trying to get new machines when it could just be something simple. So the tiered approach that we recommend is to first read the screen. There are many times options on the screen that will assist the nurse in resolving the alarm. Should that not work, Baxter Customer Support has changed their phone number. It is no longer Icon, and I'll show that on the next slide. If Baxter Customer Support cannot fix the problem, they will at least log it in their log, so there'll be a list on Baxter's side. However, Baxter does not get a help ticket placed when we call them. That must be done through our internal process, which is to red tag the machine and call the help desk at 38586 to place the work order. We highly encourage nurses to snap a picture with their smartphone of the error code. Whenever there's an alarm, there's no PHI visible on the screen, and this way they can refer to it, especially because the alarm code is fairly small. It can be difficult for them to remember to look at it or even see it if they're not thinking about it. And then, of course, we place an order in Epic for Agility to come take away the old machine and bring us a new machine. If the machine malfunctions in such a way that it impacts patient care, we encourage the nurses to fill out an incident report so that we can track these incidences and improve in the future. As I mentioned in the previous slide, Icon is no longer affiliated with Baxter. Their helpline has been taken completely internal, and that new number is listed on this slide. We've tried to put it on stickers on all of the machines, but since those get taken off with some regularity, we encourage nurses to put that in their cell phone or their Volt phone contacts list. The CRRT SharePoint is available 24/7. It has multiple documents on it that you can use for refreshers. We put the entire new user course on there, for example, and we also have documents for validators to practice their charting, to do troubleshooting, and that much and above. So if you just go to the SharePoint site from your email and type CRRT, you can find it, or you can use this link. Moving on, we gave the results of a survey that we sent to the nephrology providers back in October. We had a response rate of 10 out of the 30 that we sent, and this included physicians, nurse practitioners, PT, OT, fellows, pharmacists, and then I believe we had a nurse manager that was on it as well. I won't read these verbatim, but I wanted you to have the opportunity to see what they said. We did ask, what is one thing that you wish nurses understood about CRRT that would make things better? And generally, they spoke highly of the nursing staff. They emphasized the importance of therapy being relatively continuous and charting accurately, as well as dosing our drugs accurately. When we asked them what they thought they did well, we got pretty overwhelming responses that they thought that we did a great job with interdisciplinary care on CRRT, that we were hoping that the education was working, and they seem to believe that it does. Lastly, areas of opportunity. There's still a lot of work to be done for CRRT at UK and indeed nationwide. It's still a relatively niche therapy compared to the volumes that we do of other therapies. And accurate data reporting is really helpful. It's crucial, actually. for improving some of our outcomes. We also had the sentiment that CRRT will not save a patient who's gravely ill. It is merely a tool to support them during their recovery. So moving on to troubleshooting, I'd like to introduce the PACE framework, and that stands for Patient, Access, Circuit, and Equipment. So under P for patient, the first thing we want nurses to think about when they're experiencing issues, whether it's an alarm or just general concerns on CRRT, is what patient characteristics may be affecting the issue. For example, a patient who is in DIC may be clotting off more frequently. If they're severely hypothermic, we may see issues with blood pressure. And of course, we may have a patient who is a chronically ill patient on hemodialysis that has switched over to CRRT that may have additional considerations. Moving on from that, we consider access, and usually that is the form of, is our dialysis catheter fully functional? We also want to make sure that our dialysis catheter has been appropriately placed. You may recall that the trialysis catheter has a red and a blue port in general. We use trialysis specifically here at UK Healthcare. We want to make sure that those catheters are being inserted in deep enough and in appropriate locations. So the preference per KDIGO is the right internal jugular vein, and typically for most adults we would use a 20 centimeter catheter for that. If you go much shorter, the 15 centimeter catheter tends to stay up in the SVC, and we'd like to see that down towards the cavo-atrial junction. And without having really good flow around the tip of that catheter, you're likely to get a lot of access and return alarms. Likewise, if we use the left internal jugular vein, we prefer a 24 centimeter catheter on most adults in their current size. FEM placement is actually second preferred after right IJ placement per KDIGO. I know that historically we've avoided that for catheter infection reasons. However, the actual CRRT and HD run much smoother in a FEM line than a left IJ. We also have options such as subclavian, which are fairly unusual, as well as tunneled lines. So those all kind of fall at different places of the patient's stay in the hospital. Next, we have circuit. So this is where we consider some issues with the circuit itself. It could be that the circuit has clotted or clogged, and we'll talk about the difference here in a second. It could also be that some part of the circuit is not loaded onto the set properly if it's an alarm that has happened after the set has been primed and the patient's been on therapy. For example, it's not at all uncommon for the machine to get moved and for one of the pressure pods to get dislodged slightly and read pressures that are essentially impossible, which will prompt the machine to, usually it's intelligent enough to figure out that a pressure pod has been dislocated. As far as clotting and clogging, clotting is when a cross-section of a straw becomes obfuscated by the clotting factors in a patient's blood, and this increases the pressure drop, or delta P. Whereas clogging is when one of the micropores on a straw starts to get clogged up with solutes that are being removed from their blood, and that's associated with TMP, or transmembrane pressure. One way to remember that could be that TMP equals too many particles. When a patient has a filter that is clogged and their TMP rises first, there's not a whole lot that can be done as that filter has reached the end of its natural useful lifespan. However, if the filter has clotted, and the delta P, or pressure drop, has been rising steadily, this may be an indication for citrate if the patient is appropriate for it, or if they've been on systemic anticoagulation, it is still appropriate to add regional anticoagulation through citrate, and that's something that some providers may feel uncomfortable with at first due to lack of experience. However, it is a fully valid method of keeping the circuit functional. Lastly, we have equipment. Has your machine malfunctioned, or does it require some sort of intervention? So these machines are geared to alarm on the conservative side, meaning that they should alarm in case there's any hint of any problem. And sometimes that does generate nuisance alarms. So this is where calling Baxter customer support can really help you and the nurse that you're assisting in resolving an alarm that they're not sure about, as opposed to taking down a set and putting up a new set and spending anywhere between 30 minutes to an hour doing so, depending on other issues on the unit and the patient's acuity. So using the PACE framework, we can kind of go from the most important, which is of course the patient, to the relatively unimportant aspect of equipment, because a lot of times we find that it is not a true failure on that end. So I'll spend a few minutes now talking about documentation, because this is an area that nurses have a lot of questions about. And it's also something that you yourself may not have a whole lot of experience with if you've been in the eICU for several years, as we've upgraded to Epic. Documentation is important for a lot of different reasons, many of which are taking care of the patient, but as well as gathering the data that we need to improve our practice. As far as the bedside nurse is concerned, it's going to be how they calculate a proper PFR, which is patient fluid removal, to achieve a proper balance. Alright, so as far as general themes of documentation, we know that we're going to do it every hour, and it's going to follow a 1-2-3 flow, 1 being vitals, 2 being the I's and O's, and 3 being the CRT flow sheet. If there's a prolonged system downtime, typically they are resolved in 30 minutes or so, nurses will find the need to find alternate methods to do this documentation. Rather than going back and recharting multiple time columns, they do have the option of putting in zeros for the downtime and putting the summative value of all the I's and O's in that last column. Sometimes we have patients who are morbidly obese, super morbidly obese, that require 2 machines, during which the prescription will be split in half for the actual clearance of solutes. However, the patient fluid removal is usually confined to 1 machine, eliminating the need to do additional math on the CRT flow sheet. Documenting both sets of flows can be challenging because one will have to be done on paper to ensure an accurate capture, and this may be where the nurse turns to you for assistance, especially in the extreme circumstance that a patient like that may be paired with another one. So let's talk about initiating therapy. When initiating therapy, a nurse may use you as a co-signer for their order, in which case that is a good utilization of your services. You can find it under specialty orders under continuous renal replacement therapy. It's going to give you the run mode, which is how they're actually running the patient, the filter type, the patient fluid loss or gain limit, the blood flow rate, the ultrafiltrate goal type, which is going to be 0, even, or net negative. And if it is net negative, they'll give you a range. Typically, a temperature setting is ordered at 36 degrees Celsius. However, this is titratable. The fluids that are on the CRT machine will be found in the medication administration record, or MAR. Typically, it's easiest to do that by filtering under continuous, and the scale that each one goes on is in the administration instructions at the bottom. Prescription verification, like I said, this is going to be a good opportunity for you to be able to help out the bedside nurse. Once you verify that the machine is in fact set to the ordered settings, you can go into their CRRT flow sheet and you will place your own name as the cosigner for CRRT cosign for RN. That way the audit trail reflects that you charted your own name and that somebody didn't just pick your name to chart it. This is what they're taught in the new user class. So moving on to the 1-2-3. Step 1 is vitals. This is a reminder that all patients on CRRT must receive a temperature hourly per policy, even if the Thermax or external heating or cooling is not being utilized. Step 2 is going to the intake and output flow sheet. If a patient has multiple KVOs or med lines, they may be added together in this flow sheet row. For example, if you had 2 KVOs and you had cleared them and it was 57 and 28, you would just type 57 plus 28, enter into that line, and it will do the math for you. When doing the Infusion verify all for multiple medications. This is verifying that the rate is still the same, and Epic will attempt to calculate a volume based on the ordered weight and the documented rate or dose that the patient was on. This only works if the pump is set for exactly what the drip was ordered to weight-wise, which is frequently different, we have noticed in our practice, because nurses tend to program their pumps for the patient's admission or dry weight, whereas the providers, when they order the weight, the drug, it will default to the most recently documented weight. On the intake and output flow sheet, when you do the infusion verify all, the default for the citrate used to suggest whatever rate it was ordered as the volume. We've put in a ticket for it not to document that volume, but because I don't know when that's going to be fulfilled, right now we are teaching people to just put 0 there, because remember, citrate is on the white pre-blood pump, or PBP, of the CRRT machine, and that volume is never delivered to the patient. And finally, the actual fluid removal from CRRT is the PFR, or patient fluid removal, that was on the history screen or the front screen under status for previous hour. Some tips and tricks that we teach the nurses, and you may pass along as well, is that at least for that first hour, the nurse should manually clear their pumps. That way they can, when they go to chart them, they can ensure that whatever Epic is suggesting as the volume is accurate to the nearest milliliter. Using the power of addition is great because you can put multiple values in one row and let Epic do the math, thus reducing the possibility of user error. Using the power of infusion verify all can be helpful as long as all of your drips are programmed exactly as such, the way I stated on the previous slide. But remember, citrate does not get delivered to the patient. It should always be marked as 0 mLs. And then we say, don't forget to use the power of your brain. If what Epic is suggesting goes against what you know the patient is receiving, this means that something somewhere is wrong. Either your pump has been programmed incorrectly, or that order in Epic does not match what we're actually doing. So that was step 2, the eyes and nose flow sheet. Step 3 is starting the CRRT flow sheet. You'll start under the treatment type, and you'll say the treatment type with the status and the filter type. Note that you will typically see the ST series filter charted here, as we no longer do the HF or the M series. Moving on to the fluid balance portion, this is the significantly most confusing portion of this. So we'll start by selecting an hourly UF goal, either 0, which is when the nurse sets the machine to 0. This patient will continue to get positive every hour as the drips that they're getting start to accumulate on the patient's volume. Even is when we add up all the drips on the patient, all forms of intake, subtract any forms of output besides CRRT, and pull the difference on CRRT. And then, of course, net negative is when we work on reducing the overall fluid overload on that patient, which is what evidence has shown us most patients should achieve if their treatment is running accordingly. Based on the patient's condition, however, we may not always be able to pull what we desire. The example I like to give is that patient on 4 pressors with a lactate of 10 with a provider order of a UF of net negative 200 is simply not realistic. And we don't want the nurses to chart negative 200 in that case, because the flow sheet does not know that the patient is very sick and that that is not appropriate. So in cases like that, we would instruct the nurse to change their goal to even or perhaps even 0, and then contact the nephrology provider for a new UF order. In this particular example, the nurse has an order for net negative, so they've selected negative for this line. For this next line, the nurse would leave it completely blank if the order said 0 or even, or the nurse was attempting to pull 0 or even. But since in this particular example they were given an order of 50 to 100, they have selected a single number within that range. Note that if you put 50 to 100 in the goal desired net fluid removal, Epic thinks that you are asking it to say 50 minus 100, and it will change it to negative 50. If any negative number is in this value, it will end up subtracting it from the patient's overall goal instead of adding it, which is what is supposed to happen. Patient intake and total output for the hour can be directly obtained from the sidebar summary. This is also a good time to check and make sure that all intakes for that hour and all outputs have been documented. If you look on the sidebar summary to the right and you notice a double dash during an entry that should have volume, say for example, the second one down, which I believe is a KVO in this case, had double dashes, that would mean that the nurse had not charted anything for that hour. That may be appropriate for certain things, but if there's a continuous drip and you know that it was running, this is a great time to stop, erase what you're doing, go back to your eyes and nose to correct the error. Note that we are only taking the total intake and the total output for each hour. There's no math or altering of the data that's coming off the sidebar summary at this time. For night shift nurses, they do not get sidebar summary from 23:01 until midnight because the sidebar summary is always for the current calendar day. This information for that 1 hour should be obtained through the regular summary under the intake output tab, filtering by table and Q1 hour, and you'll see them highlighted in red on the right. The image on the left is the sidebar summary just expanded to better illustrate what you're looking at. Moving down, we then see that the flow sheet will auto-calculate several different variables. It'll be the patient balance, which will just be the total intake minus the total output for that hour, excluding CRRT outputs. It's going to give a deficit from prior hour, so whatever they were supposed to pull off from the prior hour and didn't get to. So if the goal was to pull 80 and they only pulled 60, the deficit from prior hour would be 20. And then it's going to do an actual balance, which is going to be your patient balance plus your deficit. Lastly, it will use the goal to generate a suggestion at the bottom. In continuing to chart on the CRRT flow sheet, the nurse maintenance is going to consist of the machine number, and that's the big black number that we have taped on the front of every machine, as well as the left-hand side with the label maker. It is not simply the 20 that is right below the heparin syringe. That is reflecting the fact that it's a 20 milliliter heparin syringe. We're also going to attest that the nurse has looked at the deaeration chamber, seen no clots, and moved it to an appropriate level, and then what warming device we're using. So the Thermax is fluid warmer, and it's typically set to 36 degrees. Under machine parameters, these should all auto-enter, but if for some reason they do not, it's only necessary to chart the flow rates and the pressures, as the therapy type and serial number are already reflected elsewhere. The filtration fraction may be found under the patient tab at the very bottom right on the CRRT machine. It is not the post-filter hematocrit, which is shown on the front screen. Override actual balance is the row that a lot of nurses don't use frequently because it's not necessary, but there are some situations where it must be necessary to correct a calculation. So in the example of a massive transfusion, so if a patient receives, say, 600 milliliters in an MTP, this volume must be charted under intake under the MTP. However, we would never want to pull that fluid off of the patient. So what they would do is use override actual balance to subtract that. The same can be said only for a negative sign for the paracentesis or thoracentesis. Some patients who are receiving fluids for insensible losses may also have this corrected during override actual balance. And some providers prefer that stool not be included if there's a very high volume with a quantifiable source, such as a Flexaseal. This also is the way to correct an error that you can identify in a previous time column or a general trend of things going wrong. The way to use that row, and it's not labeled on here unfortunately, but on the fluid balances, that second from bottom that's blank on every line except for 0500, that is where you would type in the patient's actual balance minus whatever volume you wanted to take off the flow sheet. So for example, if a patient had 1,154 as their actual balance for the prior hour, and you wanted to take off a certain amount for the 0500 hour, you would type 1154 minus and then that volume. So let's say it was 500 milliliters. Likewise, if you had a para or thoracentesis that put your patient into the negatives, let's say your patient actual balance was negative 3,500 from a paracentesis that took off 5 liters, you would simply type minus sign 3500 plus 5,000, enter, and it will update the actual balance for that hour. When correcting an error, if you can easily see in a previous time column where the error was made, let's say the nurse accidentally charted 1,000 intake instead of 100, you would take that actual balance for that hour minus 900 in that case, and it would fix it. There's any number of different errors that you could encounter that you could fix, but in the patient where their flow sheet is what I would call hopelessly broken, this is also a way to reset it to something more realistic. So for example, if the patient's suggestion was to pull 4,800 milliliters next hour, one might look at their overall eyes and nose balance for the last couple days on CRRT and come up with a more realistic number. Sometimes that must be done with the discretion of the nephrologist if it's going to be a big change. So we've got some what ifs because these always come up. If we miss an hour of charting, we encourage the nurse to go back and do that hour of charting. So you would chart your 7 o'clock eyes and nose and then your 7 o'clock CRRT. And then they would chart their 8 o'clock eyes and nose and 8 o'clock CRRT. If you chart both your 7 and 8 o'clock numbers in your eyes and nose and then attempt to do your CRRT, it will be wrong. So the CRRT flow sheet and the INO flow sheet, each time column is married to each other. If you have a really busy patient or the nurse is experiencing really high volume task requirements, we suggest that rather than charting perfectly for a few hours and then missing a few hours, that they simply go for every other hour. Remember, consistency is more important than perfection. If auto enter isn't working, we talked about that earlier, but the numbers that are most important to chart under that auto enter are going to be your flow rates and your pressures. If you make a mistake late and you don't discover it until late in the day, rather than deleting all of your eyes and nose and your CRRT flow sheet for all those hours, we recommend that you just correct it in one fell swoop in the CRRT flow sheet using the override actual balance. The person before us really messing up the flow sheet is when you would have to reset it to some sort of reasonable number. So for example, if the patient has been on CRRT for 48 hours and their goal was to be net negative 50 per hour, that means they should be 2.4 liters net negative. If that patient is only in fact 2 liters net negative, you could reasonably assume that there is a 400 milliliter actual balance. I know it won't ever be that clean in real life, but that's what I mean by finding a reasonable number. And then of course, excluding an intake or output, you would use the override actual balance. These are some reminders. Again, the flow sheet suggestion is only a suggestion. Always pull based on the patient's condition. And as the patient's goal continues to be the same, but the PFR gets less and less, the suggestion will continue to get bigger and bigger. Lastly, if you know that a patient is getting a large intake at a later date, or a later time rather, and you know that they are stable, you are allowed to pull ahead. So instead of pulling net negative 100 for the 8 o'clock hour, you may choose to pull net negative 150, knowing that at noon you have a large antibiotic to give. How much is too much? Well, generally, if your patient starts to become destabilized, you may see it as a new onset hypotension, a significant increase in pressure requirements, usually greater than 10 to 15%. They may have new onset tachycardias, particularly dysrhythmias in the atria. Instead of just cutting the PFR to 0, however, we recommend cutting it in half, because when PFRs are changed to 0 on a whim, patients don't actually stabilize in any reasonable time frame, and oftentimes it is not readdressed for many hours after the event. So I wanted to take this time to thank you for viewing this presentation. It went a little bit long, and if you have any questions, I've left my email on the previous slide, and remember the CRRT SharePoint is always open. Have a great competency season.